Good morning, everyone, and welcome to Blue Cirrus's final webinar of 2021. Cannot believe we are at the end of the year already. It's gone by so fast. Our fearless leader, Michelle Hager, is unable to join us today due to a traveling conflict, so you're stuck with me. I'm Amanda Powers, the practice director for Blue Cirrus. More importantly, though, I have Teresa Rincon here to share some really exciting information and education with you today. She is amazing. Quickly, if you have questions along the way during the webinar, we are monitoring the chat box. Jennifer, our amazing assistant, will let us know if you have questions and we will get those answered for you. And without further ado, Teresa, I'm going to let you take it from here and let you introduce give them a little bit about your background and let you get started.
Great. And I'm hoping you can see my screen well. I've got a black box that pulled up here. Let me see if I can get that out of the way. There you go. And I hope you're able to see my screen okay. My name is Teresa Rincon, and as you can see, I'm an RN with a PhD, and I have a strong background in critical care. I started my career in critical care in Northern California as a bedside nurse in 1997. In 2003, I transitioned to work part-time in an tele-ICU environment, along with continuing to work part-time in the critical care environment. And I helped start the first ICU on the West Coast and the second in the nation. So for the tele-ICU department, and it was brand new. We had no idea what we were doing. We had kind of a skeletal format that we followed, and we really had to be creative in how we designed our practice from the tele-ICU environment as nurses, as well as partnering with our physician and intensivist partners at the time. And we worked with other brand new tele-ICU environments that were cropping up around the nation around that same time in 2003. And then I became the manager of that department. Later, I became the director. And before I left that particular healthcare system, I was the director of nursing for both of the tele-ICUs. And we covered over 500 square miles. And we had 26 acute care hospitals, over 400 ICU beds that we worked with. And we also engaged with our emergency department partners. In 2013, I was recruited to work at UMass Memorial Medical Center in their tele-ICU and run that particular department. I was finishing up my PhD, continued to work on that while I was at in that particular role. From there, I transitioned to working on the electronic health record as the critical care champion. So I have background and experience in working with the electronic health records, and my minor studies, in fact, are in applied healthcare informatics in my doctorate of nursing degree. I transitioned to the director of all things telehealth at UMass before coming on to work exclusively now with Blue Cirrus Consulting. I do teach on the side as well at the medical school there in UMass Worcester. So that's just a little bit about me, but what I am here to talk to you today about is something that's become very near and dear to my heart. It's something that as a nurse, I've always been interested in, and those are those social determinants of health. And so today we want to talk about the digital divide, but hopefully where we can pinpoint where social determinants of health and telehealth can collide to improve upon that digital divide. So today we're going to examine some tools available to conduct a community health needs assessment, and I'll describe what that is in a minute. We'll describe where to locate lists of available resources in target areas, discuss ROI, so return on investment examples for social determinants of health programs that are powered by telehealth technologies. And so just for a general introduction, those of you that have never heard of social determinants of health, those are those things within the environment that allow people to connect to community services or not, or the lack thereof. So really looking at food deserts, homelessness, safety, sanitation in the living environment, access to healthcare services, lack of broadband access, economic stability. All of these are part of the foundations of individual and collective health. And analyzing social determinants of health can be used to inform planning and successful implementation of equitable digital health strategies. And so we know that word equitable is really important right now. We hear about it a lot. We're very focused and sensitive to the issues around it. And we believe that analyzing social determinants of health can help us get to more equitable care. Caregivers in the community can facilitate the use of telehealth and help to bridge that divide in these vulnerable populations. So go into more detail on some of the background industry terms and trends. So what, why, how, what is all this stuff about a community needs assessment? Well, needs are those gaps in between what is available or present and what should be available or present in an environment or in a population of patients or people. Resources are the assets that can be used to improve the quality of life. This can include the individuals in the environment, organizations, institutions, buildings, landscapes, equipment, even culture. In addition to uncovering the needs and assets, a community needs assessment can reveal that underlying culture and social structures that can inform strategic decisions related to how to address the community's needs and utilize its resources. This is a really busy slide. I just want to briefly show you an example of working with one of our clients, how we went through and looked at hospitals in multiple states. I've intentionally hidden the hospitals because I don't want you to focus on those. I want you to focus on the fact that through a systematic evaluation, you can pinpoint which areas. You can see these darker gray areas. These are indicating that access to behavioral and mental health services was a big need in every single one of the communities served by these particular hospitals. And we do have at the bottom as well a tally going on so that it tallies. You can look across there to see which ones, but just at a glance, you can see which areas. So this is cancer, cardiovascular or heart disease issues, diabetes, nutrition and physical activity, obesity, smoking cessation, etc. And we do expand on multiple variables. We also look at behavioral health, maternal, newborn and pediatric children's health, aging populations. Again, same kind of idea here where you can see the gray areas at a glance. You can see that drug use is a high prevalent problem, as is suicide and maternal and infant health. And so then we're able to take these and rank them as the top community health priorities in the communities that this particular client of ours was serving. And we can again look at which ones, how many were in, had 21 issues related to and which categories they were. And we can also look at do a full plethora of interviews with respondents within the organization to find out what they felt were the highest clinical priorities, and then we can match those up to see where do we have a match. So what the organization thinks the clinical priorities are and how well those actually match when we do the community health needs assessment. Now, these hospital assessments are done by hospitals. I think all but maybe critical access and very rural hospitals may not participate in this. A lot of it has to do with funding, with their status, to receive governmental supplemental payments and reimbursements. But this evaluation is extremely important. It has to be done every 3 years. So if you're working with a particular hospital, you can usually go to their website and put in community needs assessment, and you will see what the hospital has ranked based on their evaluation, what they think are the highest priorities, the things that they're going to be targeting, and then the things that maybe they felt like they didn't have the resources to target. So from a business perspective, if you're providing a service or if you are the hospital and you know there's a group of problems that you don't have the specialists or the bandwidth to address, this might be a time where you want to partner with an outside entity or service provider to fill that gap for you. But when we look at social determinants of health, we can actually do those evaluations at county levels. Some counties will do them, some cities will do them. The city of Worcester, which is close to me here in Massachusetts, they have one recently that they've done. So there is an availability or the access to those at other levels, not just hospital levels. But when we think about social determinants of health, those are those environmental conditions where people are, where they live, where they work, play, learn, worship, that affect a wide range of health functioning and quality of life outcomes. And so this comes from Healthy People 2030. And there's the, I've put the link there for those that might want to use that link later, but they've broken it up into 5 distinct buckets: healthcare access quality, the neighborhoods or the environments, the social and community context, economic stability, education access and quality. And some examples, again, we've talked about this a little bit, but access to nutritious foods and physical activity, access to healthcare, safe housing, transportation and neighborhoods, racism, discrimination, violence, income, job opportunities, education, polluted air and water, how clean are those for us in the environment, language and literacy skills. This information came again from some specific at the Healthy People, so you can go to that link. And one example, when you look at nutritious food, or something we call food deserts, and that's where people don't have access to grocery stores and healthy foods. So we know that our diet can impact our risk of certain health conditions like heart disease, diabetes, obesity, and then people that are living without access to healthcare services is another example, right? They have a higher increase for poor outcomes. And so inadequate health insurance, inconvenient or unreliable transportation, provider shortages, these are all things that contribute to these issues. And then when we look at something called, many of you may have heard of this, but Maslow's hierarchy of needs, it's something we've learned in nursing. It's kind of nursing 101, even in our background, our preparation courses before we get into nursing school, I learned about Maslow's hierarchy of needs. And it really looks at needs organized in a hierarchical fashion, right? Where basic needs should be met before we try to address things higher up on that pyramid. For example, clean water, healthy food, adequate shelter. These are important healthcare disparities and needs that need to be met before we can look at other problems that we might want to do, like adherence to a medication regime or better diet. We have to hit the bottom of the pyramid and work our way up. And when we look at this from the lens of the mental health perspective, we know that COVID-19, we've seen the pandemic stressors. You see in the middle, the exposure, infection, movement restrictions, economic hardships, right? Those are all parts of social determinants of health that also impact mental health. And when we start to look at how are we going to stabilize our communities post-pandemic, right? We know that the physiologic needs have been impacted because of the pandemic and because of some of the countermeasures we put in from a governmental standpoint and from the standpoint of ourselves, trying to keep ourselves away from people who might have COVID-19 and those barriers that we put up. We've reduced our mobility. This has caused food access issues for some populations, and for people, shelter is affected. And we're going to talk about that a little bit more. We also know that next level of the pyramid has been impacted, right? Increased unemployment, reduced access to resources. Individual stability is impacted by an uncertain future. So there's many things that are impacting the stability of our communities because of the pandemic. And here's one example. Again, I grew up in California. I was born and raised there. It's a state that I love. I'm not living there right now, but I still have property and family there, and I visit there frequently. And I can tell you this is real. I've seen this firsthand, the homelessness crisis that's going on in California today, in the larger cities especially. And so when you're looking at this, you can see here, this is Sacramento, because you can see it's I-80 East Sacramento, and it's the on-ramp. This is not a safe environment on multiple levels. You're close to cars passing through. They're smelling tons of exhaust so that it's not clean air area. And you can see also that unfortunately, many of these people don't have a place to put their garbage. Some of them are hoarders. They're collecting a lot of stuff. And this increases the rat population. It increases risks of communicable diseases, which we've seen in California. We're starting to see outbreaks of diseases we haven't seen for 100 years, things that not even related to COVID-19, but even with COVID-19, I think we could agree that this right here is not a good environment. It is not safely distributing where people are. They're in very close quarters despite being outside. So we're increasing the risk of a spread of the disease and probably a virulent or other variants of the COVID-19 virus being spread. So we need to address this. We need to address this from a human dignity standpoint. And because if we don't take care of these people, it not only impacts these people, but it impacts the community at large, right? It can create a public health crisis for everyone, not just the people living in these extremely austere conditions. I just want to give a plug out for the mayor of the city of Sacramento, who has been working fervently to try to come up with solutions for this. So I don't want you to think nobody in California is working on this. They are, but it is a huge problem. And I want to give a shout out to Mayor Steinberg for his efforts in this area. One of the other things that's happening in my home state where I grew up are Walgreens closing in the city of San Francisco. So 5 Walgreens by this time had closed. This was additional ones that were closing. And what this is creating is it's creating pharmacy deserts. So now we're creating in the middle of a city, a medication desert. So things to think about as we're evaluating our communities. We can't turn a blind eye to these things that are happening because they're going to impact the overall care and outcomes of the people who live in these communities. Now, from a telehealth standpoint, we know that the pandemic has had a positive impact on the utilization of telehealth tools. And so if you're someone like me who's been in telehealth since 2003, we're pretty excited about the fact that the adoption and acceptance has just improved dramatically. It's something we've been working towards because we have seen the value in it for decades. And now to see people really latching on and seeing the increase in the utilization of the tools and the patients that are being who benefit from these tools. We know, I'm not going to talk too much about telehealth care delivery terms because I'm hoping those that have joined know what telehealth is, but really telehealth is the broader term. It covers the means and methods for enhancing healthcare and public health and even health education through telecommunication technologies and tools. And many of you have probably heard the term synchronous and asynchronous. For those that are attending this session live, you are benefiting from a synchronous delivery of this presentation, but others will be benefiting it from an asynchronous perspective because we're recording it. So that's a brief example of that. We know that there's scheduled models and there's also continuous care models where monitoring, like the tele-ICU example, is going on without interruption for a defined period of times, or they may do it for 24/7. Responsive or reactive care models, which are different than those scheduled ones that allow someone to join immediately based on an alert or a page or some kind of message. And these are unscheduled and sometimes referred to as on demand. Then there's centralized models where everybody who's working as a remote caregiver are centralized under one roof and one room, providing services together as a team, and decentralized models where the remote care providers could be located anywhere. We also are probably all aware that telehealth in rural America has been a big thing since the Social Security Act of 1999. We have been able to provide additional grant funding and reimbursement for providers who provide care to patients over telehealth technologies in rural communities. And we've seen the benefits as are shown in this particular slide. We know that the market is continuing to grow. I'm not going to spend a ton of time here, but just the fact that over 1 billion virtual visits are estimated for the year of 2020 when this was. We know it's been more than that in 2021. We've surpassed that. And when we look at the US digital health ecosystem, it's exploding with the number of companies and devices and startup companies. It's almost becoming overwhelming for the consumer to determine, well, which one of these is the best one that's going to meet the needs of my organization. And I can say that's what we also do at Blue Cirrus Consulting, is we help you walk through that digital ecosystem and help you determine which of these types of technologies you might need to use or choose. And then we know venture capital funding has increased for telehealth companies dramatically. We're seeing investments, the trends of telehealth investments are up substantially. These data were taken from July of this year, and you can see where we were already. We were already surpassing the revenue in billions compared to the 2019-2020 when you look at 2020 to 2021. But the reason we're here today is we know there's a digital divide. We know that there are places where it's difficult, even in the rural setting where we have funding, to reach patients using some of these digital technologies. So what's the purpose of conducting a needs assessment before determining a telehealth strategy, right? We probably already think we know what we need, but it helps us summarize and identify the clinical priorities and the needs of that particular community. It outlines how telehealth can improve and expand care within these clinical priorities. It can provide details to the barriers to implementing telehealth strategies. Because if you just say, well, we're going to hit this population and you haven't looked at the barriers, that could become a problem if you implement before knowing the barriers. Identifying the specific healthcare issues or problems that require resolution in service areas, and demonstrate the potential impact of telehealth. So here's an evaluation of 86 counties located across 12 states, and does include the District of Columbia that I recently participated with other folks from Blue Cirrus. And we reviewed 86, yes?
Quick question for you. So with overworked clinicians, how do we create incentives for engagement with telehealth and social determinants?
Yeah, that's a wonderful question. And when you start to look at the retention of healthcare workers across the spectrum, from nurses up through pharmacists, physician providers, nurse practitioners, PAs, etc., we do need to look at how do we create an ecosystem of telehealth that allows each caregiver to work at the top of their license and the top of their scope, right? What we've done today with telehealth that I think has created a bit of a chasm and a problem is we shift the onus of providing 100% of the care and input of the patient's information for a telehealth visit on the provider providing the service. And I think what we need to do is really use the same model we'd use in a brick and mortar clinic, right? In a brick and mortar clinic, the physician or the nurse practitioner or PA, they're not working at the front desk doing the intake, right? Somebody else is doing that. A different level is providing that service. Someone else is taking the vital sign and getting the patient comfortable in the clinic room before the provider comes in to see the patient. So when we think about implementing any of these strategies, we have to think about who is the best role to do each piece that needs to be done. And I'm going to talk about that a little bit more in a minute. So I'm going to get to that question because I'm going to show you some examples of using other healthcare providers that you might not have thought of to help facilitate telehealth visits, that takes the onus of 100% of the work off of the provider, freeing the provider up to see more patients and to be more efficient with the patients they see. So I think those are a couple of the keys.
Awesome. Thank you.
Sure. I hope that answers the question. We'll have some more Q&A and maybe we can get into more of a discussion on that. But when we reviewed these counties, and I'm only showing a snapshot, I couldn't show all 86 of the counties we looked at, and I sorted these by this middle column here. population in poverty, we can look across and see there's multiple things. Some of these I'm not going to go into great detail, but I could send a list of what those are later. But if you went on this website, all of the definitions for these are there, but these are different scores. This is actually a indication of the economic stability of the community. Some of these others are associated with the actual population health. And we can see here the BB is for broadband access, food desert, hospitalization rates, cancer, asthma, diabetes, etc. So we can see the population where we might want to target, whether or not they're rural or not. This is not designated rural per HRSA. I'll talk about that in a minute. You can go to the Health and Human Services website and you can actually put in a zip code or a county and find out what's the percentage of households with broadband access. This was one that actually came from this particular analysis. And when we want to drill down at some of this information and maybe put it into a spreadsheet, we can do pivot tables and other ways of looking at this visually. So here you can see the number of populations that are living in what would be considered a food desert, with 10% or less of the population in a food desert, all the way up to greater than 40%. That's the 40% is the slice here. Might be hard to see on your screen. But you can see there's a large piece of this pie if you added up these three, which are your highest rates of food deserts. And we know that those impact patients. We can also look at, this is the designated rural, where I went to each county and we looked up whether or not they were designated as 100% rural in the population, or whether just some of the addresses were considered rural. We can see for this particular client, 49% of the counties that they served are considered rural or partially rural by HRSA. And then when we look at broadband, right, you can't really provide telehealth services without broadband access. We can see by each of the states that we assess and the DC area, where did they fall in relation to broadband access. So these are percent of households with broadband, and you can see there are counties in Georgia that are less than 50%. And there is one that's about 71% of the counties we looked at. Then you can see the yellow coding are those that are, right around 92% or less. And then if we wanted to sort the data by mortality rates, I did that here and looked at it. And you can see there are some counties with substantial problem with mortality rates, right? So these are counties in which we'd really want to look at, why do we see, here's another one down here, Jennings, why do we see such high rates? And so these rates here, this is 206,000, 206.9 patients per 100,000 population that have a mortality for cancer. And up here we see 222.9. So really important information as you're thinking about what areas you're going to target and what clinical priorities you're going to target. This is another county rankings.org, healthrankings.org that you can go to. And here what I looked at were overall health outcomes and then health factors. So what are those things, those behaviors and those things that might impact health outcomes? And then in looking at the same counties, what are their actual health outcomes? What are they dying from, or what are they reporting as healthcare problems? It's accumulation of that. And so it's kind of nice to look visually at this. As you look, you can kind of see which targets are obviously in the state of Arizona, some pretty big areas that someone might want to target for looking at that. You can also go to this website called Data USA. This one is focusing on Appalachian, Virginia, and looking at the counties in there, and it gives you some high level data, but it also gives you data that you can drill down. The nice thing about this resource is that you can create a cart. So you can choose specific elements that you want to put into a data cart. And then at the end, you can take all of those data and combine them and download them into a CSV file to do your own analysis. In Virginia, since we talked a little bit about Virginia, there's the ARC.gov, which is the Appalachian Regional Commission, and they have a plethora of reports and information related to everything from economic to healthcare issues. This first colorful map here you see with the red counties highlighted as distressed counties is looking at economic status. And these are Appalachian counties that have high risk or distressed areas. And then there's at-risk counties that you see in the kind of peach color. And then within some of those counties and areas, you can also see distressed areas. And then if you started to look at that from poor or fair health, so this is percentage of adults reporting poor or fair health, you can see that the same dark shading occurs along these areas here as we see over here. So they're economically distressed, and there's also poor to fair health. And so in working with one of our clients in using this form of evaluating, both from interviewing the leaders within the client's organization and looking at the social determinants of health and community needs assessments, we were able to target a market for them, looking at patients 65 years and older, rural locations, since the one that I did show you the example of had 49% of their counties were either rural or partially rural, chronic health conditions, community health needs in general, and social determinants of health. And what we recommended was a telehealth powered mobile integration health and community paramedicine program. And so what that would do is you've already got paramedics who are out in the community. They know what's going on in the community because they live and work in these communities. And they are the ones that pick our patients up from their homes or from wherever they're at and take them to different locations, right? A hospital, behavioral health hospital, emergency departments, other places. So they have a lens into these communities and into the needs of these patients that are difficult for us to do or have. We can try to use our home health nursing, but there's not enough nurses. We have an extreme nursing shortage. So we can't sometimes get to these patients in a timely manner. So this was one example of creating a service line to meet those needs. As we looked at social determinants of health, we said, if you're already going to be in the home providing these services or in the community, well, why not use a standardized tool to evaluate the patients and become that health navigator? There are social determinant of health navigators. I know of one in particular. One of my students at the Graduate School of Nursing at UMass Medical School in Worcester is working with a group out on the Cape, and they have helped develop some tools for them standardized tools for helping connect people to resources. But those tools could be used in the home by a paramedic, an EMS provider, a healthcare coach, and then they could connect patients to their caregivers, let's say for a transitions of care visit, right? A post-discharge visit. Maybe we have someone go into the home using a different level of care than a nurse because we have a shortage of them that could help to provide that conduit to be a navigator and to facilitate that telehealth visit. Remote patient monitoring, many of you probably know of this, but it really helps in early interventions with chronic conditions. We've seen reductions in 30-day readmissions, decreases in emergency room visits, overall better wellness and early disease detection, and improved compliance to the treatment plan. So we know that you don't get paid a ton of money for it. These are the codes, but it's about $130 per patient per month. And so there is some money that can be, hard costs that can be reimbursed for the services provided. But we also know that there are soft costs. And I'm having trouble expanding there. There we go. Some of the other costs we want to take into consideration and understand is that 47%, which is almost half of the United States hospitals, received some form of a readmission penalty at the end of 2020. And the maximum penalty for a Medicare reimbursement is 3%. There are websites you can go to look up at this KHN. .org was where this information came from, but there's information that you can put in at every hospital you work with or work within your health system to see what their history of readmission penalties have been, to look at how you might want to use something like remote patient monitoring to reduce that. Of course, anytime we're looking at reducing the length of stay. And we want to be careful with that because as you reduce length of stay, we could increase readmissions. So we're trying to get people out of the hospital faster because we don't have enough beds in many hospitals, and that creates a problem. So now how do we target healthcare providers in the home working with these patients? Another one I'm not going to talk about is hospital at home. I didn't show a slide on that, but that would be one that many people are also using to get patients out of the hospital faster. 911 telehealth support services was an example we recommended for one of our clients, and that was really using a facilitator role to assist in the field and in the patient's home with a telehealth response. And so these are some of the codes that the provider could bill for. And remember here, the provider, if they're doing a telehealth service, they're not having to pay for a fee that they would to pay for someone to check their patient in the clinic. So consider paying that fee to this facilitator role over here so that they could help you connect to these patients faster. I know of one group out of Arizona that we're partnering with that's been providing some services like that. We're now going to try to bring this to a more comprehensive service offering in which we're partnering with a ambulance provider. Telehealth, mental health screening and assessment. That's one of the things we can do. This comes from SAMHSA, on telehealth. This is a document you can download, but it is showing the idea of being able to screen and assess. And then from there, after we've screened and assessed, branching off and moving to the patient to whatever support services that they need. And one of the examples they used in this, and I actually worked with a client out here in Massachusetts on a program that they put together, which was suicide screening and assessment. And they were actually doing it in the emergency department. They're running a study on this right now. So more to come on the outcomes for that particular group and the research they're doing. But it really looks at decompressing our emergency departments by allowing a trained behavioral health specialist to screen that patient over video. If you're not aware of this, what happens when a patient comes in is in our emergency departments across the country, they're screened by nurses and physicians and advanced practice providers that will tend to err on the side of safety and put this patient under a suicide risk in a one-to-one status. This is clogging up our emergency departments. In some very small emergency rooms, we have up to 12 to 15 patients a day on suicide watch, which requires a one-to-one observation, which means I have to be close enough to reach the patient. So I have to be about 3 to 4 feet away from the patient while I observe them. And so this allows us to actually have a mental health specialist screen the patient to make sure that we've screened them appropriately. And what we find is that we get them off those suicide screenings faster. And that saves a lot of money from a standpoint, a resource intensity standpoint of managing patients on a one-to-one status. So when we look at keys to return on investment, we have hard ROI reimbursement, cost reduction, like the one I just talked about with suicide screening, cost avoidance. We also have the soft ROI, which are those quality improvements that we want to look at, labor capacity and efficiency, and patient and provider satisfaction. And I want to talk a little bit about some of these quickly, but patient satisfaction is one I really want to hit on. We are going to hit a little bit on reduction in readmissions as well. But when we look at translating dollars to patient satisfaction, I don't know if you know this, but patients' experience scores are strongly associated with a hospital's financial performance. In fact, hospitals with excellent HCAP patient ratings had a net margin of 4.7% on average, as compared to 1.8% for hospitals with low ratings. So really important. And patients like telehealth. And when we can meet their needs where they live, they like that even more. So this is why putting all this together is so important. So we know some of the hard ROI, fee for service, bundled payments, contracted services, reimbursable care, downstream revenue, and grant funding. And when we look across the spectrum of value-based models across payers, we're used to the fixed payment, that fee for service. We've been doing that a long time in healthcare, but shared saving models have come into play, shared risk models, and now even global capitation, right? And it's really global capitation is becoming a central driver of innovation and competition because it's focused on wellness and early intervention. So this is something that is going to continue to grow, and we have to keep our vision looking forward. And we need to think about when we use the shared models in the global capitation, how do we make sure that we provide all of the resources our caregivers need to provide the care? And if we're providing those resources, how do we pay for them, right? And so building capacity in telehealth, telehealth's a bridge for clinical needs you don't yet have. It builds capacity in your existing schedule so you can actually see more patients if you're a provider. And it can be used for bundled payment options. So another example of that would be proceduralists and surgeons. They usually are under a bundled payment method, and all of their payments are put together. They get one lump sum. They can decide how they want to care for those patients any way they want. And then access for provider specialty services via telehealth, use telehealth services to learn how to do it and then operate it independently. And then technology, of course. Is there additional hardware needed? Do you need broadband coverage increased? Do you need to provide a hotspot in order to provide the service? Does existing devices need to be reconfigured? Does a new telehealth visit type need to be created? And then are you setting up a dedicated telehealth space? Or are you doing that decentralized method? Some of the performance recommendations you can look at here, CMS inpatient quality reporting programs, outpatient quality reporting programs. There's a lot we can do. We can look at AHRQ quality indicators, health effectiveness data, and information data sets. So I hope I didn't talk too fast, and I'm available now for questions.
Thank you, Teresa. You guys, if you do have questions, feel free to put those into the chat now. Just to let you know that this webinar will be on our website in the next day or two in the Knowledge Tsunami section, where there's not only this webinar, but there's a lot of other information, past webinars, past radio shows, articles, things that you very well may be interested in. So please feel free to take a look. We are always looking for new ideas or, things that you guys want to know. As far as education goes, that is our goal. So if you would like to email those things to us, those email addresses will be on the screen at the end. So I'm not seeing any other additional questions right now, Teresa. So thank you again so much for putting all of this information together for all of us. We really do appreciate it. And thank you everyone for joining. Please, I can't believe it's the end of the year already, but have a wonderful rest of the month, holiday season, and we will see you guys next year.
All right. Thank you very much, everybody.